All right, chapter 42, antifungals. Super fun. So first, the fun guy, very fun guy, is a huge diverse group of microorganisms, and it goes from yeast to molds. People can become yeasty. We've probably seen that. In those warm, moist places. They can also become moldy. Hopefully you don't see moldy. Fungal infections, also known as mycoses, and they are plentiful. Again, in those kind of warm, moist places like the skin, underneath skin folds, in the mouth, within the intestines, and the vagina. Can be systemic, which is always the worst, cutaneous, subcutaneous, and or superficial. And then they can affect, again, those various layers of the integumentary system, so skin, hair, and or nails. We have yeast, which is a single cell fungi, single cell. It reproduces by budding. And it also can be used for less scary things like baking and alcoholic beverages. But again, yeast grows in warm, moist places. So always, always, always checking within folds and cracks. Male or female does not matter, but definitely you need to be lifting up breast tissue or looking behind knees or toes, in the mouth, behind the ears, all those kinds of places. Um, Within the cheeks, butt cheeks, all that kind of good stuff. Lots of yeast. It starts out as white. The edges will become white, but potentially a red patchy area may have, again, that kind of white border. It's probably yeast. Molds, more multicellular in nature, characterized by long branching filaments called hyphae. Um, you can actually see molds growing, not only in people's houses, but actually on people, and they will still be alive. So very important, again, that you check between toes, between fingers, where things can hide and not easily cleansed is where we're going to find some of these molds. Now, mycotic infections or fungal infections are a really big deal. They're very, very hard to cure. If we think about just kind of the four general types as far as cutaneous, subcutaneous, superficial, and systemic. These mycotic infections can be treated in multiple different ways. However, systemic, again, can be life-threatening, and usually occurs in a person that can no longer fight infection well, so an immunocompromised host. Think about mycotic infections, again, fungal or molds. Our most typical is Candida albicans, or white yeast. It's usually followed by some sort of antibiotic therapy, anti-neoplastic or chemotherapy, and immunosuppressant type of therapy, including corticosteroids. So again, lots of our patients are on multiple drug classes that are represented here. So always keeping our eye out, again, for those warm, moist places where our Candida albicans can grow. Some of the oral overgrowth is called thrush or oral candidiasis. Can also be seen, again, in newborn infants and then a breastfeeding mother, and they kind of pass it back and forth. There's a purplish medication rub salve that a mother could put on. The baby's mouth will turn a little bit purple, but that will help decrease that that candidiasis transfer and thrush. And then again, in immunocompromised patients. So our patients that do or are taking antibiotics or even antivirals, we definitely want to make sure that we are checking their oral mucosa for those early signs of thrush, which would be kind of that pinkish, reddish tinged skin with kind of a whitish border. We have our antifungal meds. They're broken down really by their chemical structure. So we have our synthetic triazoles. So our ending for that is azole, A-Z-O-L-E. Make sure that you have that highlighted, or zole, depending on how your brain wants to put it in. Our caspofungin is a very specific medication, really only kind of seeing that in more systemic fungal infections. Our synthetic Alalamines, again, very specific, and our polines, which are as our amphotericin B. I definitely want to stick to kind of our synthetic triazoles and our amphotericin B, our polines. Very aggressive drugs. You probably have already seen nystatin for sure, but definitely very used in our antifungal population. For, again, indications, systemic and or topical. Again, having a systemic fungal infection is really pretty severe, and our drug choice for that would be amphotericin B. So it kind of depends if it's a toe or a toenail or an elbow or, that warm, moist place, what kind of drug we're going to use to treat it. Fluconazole does pass through the cerebral spinal fluid, so we would use that as a cryptococcal type of treatment for cryptococcal meningitis. And then we have some very specific uses for alternatives for antifungal medications. Pamicil, again, over the counter, we can see onychomycosis, so fungal infection of the nail. If you are unfamiliar with some of these terminology, please make sure that you kind of study again more of the medical terms so that you feel comfortable seeing these on our exam. Voriconazole is also used for the treatment of aspergillus, which is a very aggressive respiratory infection. Fluconazole or diflucan, it's a pretty typical yeast medication for vaginal candidiasis. It can also be used for oral or esophageal candidiasis as well as systemic. And then we see our amphotericin B, again, broad spectrum against fungi for those systemic infections. Providing medication therapy with amphotericin B is really going to be occurring more of an acute or higher acuity type of patient care. So ICU for sure, mainly because it can cause cardiac dysrhythmias. It has some neurotoxicity such as tinnitus, visual disturbances, numbness and tingling, pain and convulsions. There's a risk for renal toxicity and loss of potassium and magnesium. There could be a risk of pulmonary infiltrates, and there can also be a risk for fever, chills, headache, nausea, hypotension, and GI upset or anemia in relationship to this drug. So, what are we going to do? We're going to pre-med our patient. Pre-medding our patient with amphotericin B is a very important thing that we do. Again, we know when we give this drug, amphotericin B, that our patient's going to have an interaction. So we always pre-med our patients that are taking amphotericin B. So we can give them corticosteroids, antihistamines, antiemetics, NSAIDs, potentially NSAIDs. We might also be giving acetaminophen. So lots of different things that we could consider giving our patient because we know that they're going to have some sort of also reaction to this medication. So the only time that we're really going to stop amphotericin B is if we know that we've pre-medded them and we've assessed their baseline, and then let's say they start becoming febrile or hypotensive. We're going to watch it. We're going to monitor it. If they then drop for a second time, that's when we're going to consider holding that medication and alerting the doctor. Well, we're going to alert the doctor after their first kind of drop from baseline or change from baseline, but we're also anticipating this change from baseline. Remember, they have a systemic fungal infection, so we really want them to get this drug, and we're going to do other measures to try and get that drug in them. So we're going to monitor, we're going to anticipate potential changes, but if those changes then change again and perhaps make our patient become more unstable, that's when we're going to consider removing the administration of amphotericin B.